Hi, my name is Nadia Khan, and I'm a third year resident at Henry Ford Macomb Emergency Department. My case study is it's not just the flu, a case study of influenza A induced necrotizing encephalitis. This is an unfortunate case of an 11-month-old female who presented to the emergency department as likely complex febrile seizure secondary to influenza at home. Mother described a 2-day prodrome of emesis, nausea, vomiting, and temperature of 106 Fahrenheit, but ultimately came to the emergency department for right arm posturing, waxing and waning, left arm and leg stiffening associated with blank stares and right-sided gaze preference. The patient was treated as such with antipyretics for SED, Ativan, and Keppra. PCR was positive for influenza A and Tamiflu was initiated. LP was performed and patient was treated empirically with vancomycin and cefepime. She remained altered without return to her baseline mental status and became hypothermic, requiring warming. CT head was performed, which was non-revealing, and she was admitted to the PICU, where she was ultimately diagnosed with acute influenza-induced necrotizing encephalitis. This condition is primarily characterized by inflammation of the brain and the parenchyma, with only about 59% of reported cases thus far. It's been linked to HHV6, measles, mycoplasma, Coxsackie, and other unidentifiable viral pathogens. It's more prominent in East Asia than in Western countries, with a mortality rate of approximately 30 to 40%, with less than 10% of patients unfortunately receiving full recovery. In regards to labs and imaging, relatively non-specific findings with transaminitis, negative CT head, you can have a positive EEG. However, this patient did not. And in regards to her ultimately finding imaging would be the MRI, which was most revealing, as you can see, with T1 hypointense and T2 hyperintense thalami, with worsening of imaging 2 days later with increased petechial hemorrhage. Diagnosis and treatment is clinical along with labs. So there's altered mental status, personality change, seizure, focal neurologic signs, headache, nausea, and vomiting. Lab work as was performed here in addition to CSF studies as part of a febrile seizure workup or fever of unknown origin in a child, multiplex viral PCR, CT head followed by MRI and EEG. Antivirals, including oseltamivir, are appropriate as they were in this case, however, with double the usual weight-based dose. IVIG, plasmapheresis, glucocorticoids, and supportive care is necessary. The pathogenesis is likely with a genetic mutation of the RANBP2 gene, but also a cytokine-induced injury that is likely not directly from the virus, but some studies show that it could potentially be. This patient, unfortunately, regardless of therapy, did end up having a poor prognosis with persistent neurologic deficits and ultimate transfer to LTAC with future neurologic disability likely related to sitting, eating, and dystonic reactions.